Can you start the recording?
Very good evening.
Hello.
I am Dr. Ajit Pillai, and today I'm going to talk on inoperable congenital heart disease in adult. I'll be broadly giving an overview and the issues, common issues, and the guidelines as by evidence. So um, I do not have any disclosures on this talk. So the flow of lecture would be to ascertain the importance of reconfirmation of status of inoperability, the various clinical scenarios, given the fact that this is a very heterogeneous group, each patient is different from one another. The function class of patients, which is very important in an inoperable cohort of patients. The pH-specific medicines, which is quite important with regard to the evidence-based medicine. Attention to specific issues in some of the patients like heart failure, ventricular function, arrhythmias, ICDs, and pacemaker, the do's and the don'ts. Interventions which are very sparingly done, they are very minimalistic, but then they need to be discussed. The management of acute heart disease in this group of patients, and lastly but not the least, actually how to prepare this patient for a non-cardiac surgery. So in inoperable gauche, the clinical scenarios, as I told, is heterogeneous. Patients with proven Eisenmenger syndrome form the classical cohort of patients whom we deal with day to day, and they are the patients who are actually reasonably straightforward to manage because the guidelines are quite clear cut. Patients with very complex congenital heart disease, where a reasonable biventricular operative success cannot be afforded in a setting, so they also come under the inoperable group. The third group is actually the far borderline or the extreme borderline cases where clinically it's near Eisenmenger syndrome, but clinical team deems it to be a very prohibitive risk to operate. So they also come under this broad umbrella. And then lastly, we have the specific situation in low middle income group where many univentricular substitutes are continued in medical care. They are deemed to be difficult to operate or inoperable in a pediatric age group, and they continue to an adult group. So re-evaluation of these patients is very key whenever you see this patient on a first time. A thorough review of the history and investigations will have to be done. Maybe hemodynamics has to be repeated. The fact of the matter is that many patients may move to a borderline status after careful review and pH-specific medicines, not clear-cut operable extent, but in the borderline zone, which makes it even more challenging. Patients with coexisting diseases, maybe acquired heart disease, will have to be addressed, like valvular heart disease, will have to be addressed to improve the quality of life. An adult gauche patient, in summary, who is coming to the clinic, is usually a well-balanced person who's frail in physiology, frail in physics, but hemodynamics are well-balanced. So any major intervention in this group should be a team decision, and it should be done after thorough planning, and one should not be jumping into conclusions. The pH-PVD conundrum is there, and this is often discussed in our peer group. We know that when the PVR is very high, 30, 40, the pulmonary blood flow is very low, less than 3, and then that makes the classical prototype. But there is a borderline sector of patients who have a PRA, PVR, which within 4 to 8, 6 to 8, but where the pulmonary blood flow is not significantly deprived. And these are a group of patients which often challenges an interventionalist or a surgeon. This cartoon or this classification is very important and fundamental, and is annexed to all the major research articles on this inoperable group, basically because it delineates the Eisenmenger syndrome, the classical type, and the class B or the group B patients who are having a large defect but significant PVR, and the dilemma persists whether to operate or not to operate. There is a gap in the knowledge, and the treatment is largely individualistic in this patient even after thorough evaluation. Then we have other groups, small defects PH, corrective surgery with PH, and then of course last but not least is the PVR, PVR in Fontan patients, which is actually we are discussing in a next session. So group B, the basic question is I can close it, but it doesn't mean that I should close it. In fact, most of the cases you should not, but clinical medicine, nothing is certain. So repair defects only when there is a PVR which is consistently below 4. When it's more than 8, don't touch. But between 4 and 8, as in any case, there is a borderline case. Treatment should be an MDT. There should be a consistent and clear-cut counseling, and you should have a clear, well laid out plan on how to go about this particular patient. The treat and repair algorithm has often coming sparingly given us some light of hope, but then again, this is not consistent. You can't just go on and plug or go on and close these defects or problems with pH therapies and then thinking that PVR drops to acceptable levels, or PVR will or has dropped to acceptable levels. This is a completely different animal. Despite case reports supporting this approach to survival till discharge, there are many knowledge gaps, like long-term survival, long-term quality of life, even sudden cardiac death. So it cannot be recommended on a day-to-day basis for all patients. The function class is key for these patients. The quality of life is key. The ventricular function is important. The rhythm status is important. Univentricular hearts, the status of ventricular function is key to survival. All of us know. The 6-minute walk test may help in titrating pH medicines, and we can give a good quality of life. That is what we are supposed to do. What are these pH specific medicines? So-called quoted as advanced therapy, which include class of angiotensin 1 blockers, the class of phosphodiesterase inhibitor, the class of prostanoids, which are predominantly intravenous parenteral forms, and of course the oral selexipag. There is lots and lots of RCTs. Many are not published, many are ongoing, but the data is clear, loud and clear. We do have benefit with these medicines. So Breathe 5 is a landmark trial in this regard. Bosentan is a prototype drug. Eisenmenger syndrome, it improved hemodynamics, quality of life, exercise tolerance. So this has helped us in putting it in the guideline. This is ESC 2020, which helps us in precapillary pH. Initial combination therapy or sequential combination therapy is recommended, and high-risk patients should be treated with combination therapy class 1A. And in Eisenmenger syndrome with reduced exercise capacity, monotherapy should be considered, followed by combination class 2A. Phosphodiesterase inhibitors, we have very wide experience in our country with the prohibitive cost of angiotensin 1 blockers. But again, there have been not robust research on this, but data on this. But again, we have on clinical parlance, we have shown that they improve exercise capacity and hemodynamics. There is a catch here. Sequential and additive effect with 81 is not clearly proven, but we often give this as a benefit of doubt. And it has probably not harmed the patients. In coming to Prostab, selexipag is very convenient because it's in the oral format, especially it is being given in patients who have high risk of complications of mortality despite dual oral therapy. In NYHA class 4, the recommendation clearly tells us that parenteral prosta is the way to go because they're already morbid, and then the issues with parenteral prosta in the last decade or so, we all know that drug stopping and all this patient becoming discomfort. So all these issues are not adding up to the already the misery the patient is having. Maybe that may be the reason, but I also feel that probably for class 4 patients who are terribly ill, this may offer a ray of hope in prolonging the comfort. So in PH patients with group B, there is a controversy, which often we have discussed in our peer group, is that we all know that there is an increased pulmonary blood flow, large shunt, cell shunt is there. That's why we are clubbing it as group B. The problem is angiotensin blockers is going to increase further the pulmonary blood flow. So this is a little bit counterintuitive. There is some data on this because they have shown us that there are exercise-induced favorable changes with therapy. So there is a catch, there is a knowledge gap, but then again, it's highly individualized care. In Eisenmenger physiology, should we use this, especially in univentricular heart? There is no evidence. RCTs have excluded this group, so we really don't have the data. But in an individual case, you can try, but the important thing is actually one must be clearly monitoring the ventricular overload and ventricular dysfunction because they increase the pulmonary blood flow. In failing Fontan, there is no significant recommendation. There is no evidence to suggest this will be beneficial. In heart, so there is another lecture on this, so probably we will skip this. So heart transplantation, often hyped about, but moving this in Eisenmenger syndrome, even in developed countries, is a challenge. We have some data which shows that it improves the outcomes. It prolongs the survival, heart-lung transplantation, but this forms Eisenmenger syndrome and grown-up congenital heart disease form a different track compared to the conventional heart failure, the dilated cardiomyopathy group, or the ischemic heart disease group. So, and this group has a as compared to the other groups, they are better survivors. So probably they're not listed as a priority, and then there is something which is missing in this coming heart transplant as a front runner for Eisenmenger syndrome. Another thing is actually they are often multi-system problem. Our Eisenmenger patients are much sicker, are multi-systemic, so that is again going negative for the transplant. So coming to the palliative, somewhat the palliative catheter bites and palliative catheter by sports shunt as well as surgical PA banding. Even we have now percutaneous PA bands, but most of the enthusiasm has already been waned off. So it's a totally it has given us some hope, but probably the patients are too morbid and too much of mortality. So probably now this is not probably to be recommended. So coming to the systemic complication of Eisenmenger syndrome, the cartoon suggests, they have multiple problems: liver, kidney, the brain, then hematological issues. So they are multiple. So coming to the key recommendations and key factorials on this area, secondary erythrocytosis. This is not like polycythemia vera. So time and again we have realized this. Actually, routine phlebotomy should be strictly avoided. It actually worsens the outcomes in terms of neurological, in terms of oxygen carrying capacity, and worsens iron deficiency. So only couple of situations where you recommend phlebotomy. One is actually autologous blood donation, and most importantly, actually patient who have hyperfocus symptom. Another small indication is actually patient when we are subjected for non-cardiac surgeries. When we find, especially when we are in a dilemma with regard to hyperfocus syndrome, we often actually recommend phlebotomy. But it's not it's a rule. Oxygen therapy, chronic oxygen therapy is not indicated. So it can have added problems. It's not clearly going to give you the benefit. Neurological complications, couple of things we should know: that the secondary erythrocytosis is not something which is a fundamental reason for neurological complication, whereas iron deficiency and microcytosis are. So this we should clearly understand. And please you educate your nursing staff, even for routine IV line putting. Please use air emitting filters. Many of these patients go for contrast CT for brain, and also that is something which is important. It has come in the guidelines as well. So coming to thrombotic complications, I'm rushing through for want of time, but again, thrombotic complications are very common in this group. Pulmonary thrombosis has been reported in a substantial number of Eisenmenger patients, but when we anticoagulate them, they often bleed, and then probably that is a reason why anticoagulants have a strict no in this group only for thrombosis. They can be given in a tailored manner in a very, very definitive duration of therapy, but routine blanket treatment with anticoagulation is strictly no. So what are the indications for anticoagulation in this group? One is atrial flutter or fibrillation. Second is documented DVT. Third, patients who are having prosthetic heart valves, and largely ICDs and pacemaker, especially when there is a shunt lesion. And also, if you have a baffle leaf, it's better to close the baffle leaf. In fact, it is better to close it before you put in the pacemaker leads. Heart failure. So heart failure in an Eisenmenger is underreported. I would say it's not that extremely rare, but it's underreported. But again, we are extrapolating our experience with heart failure therapy, the routine heart failure therapy in this group. But we please should understand that that is something which is not to be kind of supported, but we still give. The data is limited and evidence is doubtful, especially in univentricular situations. Hemoptysis is a very important thing in this group of patients. Almost 100% do manifest some degree of hemoptysis. There can be fatal hemoptysis, and sometimes we may not be able to save the patient in a massive hemoptysis situation. But in cases where they are salvageable, I think a transcatheter way of angioembolization is a way we can help them. Non-cardiac surgery is the last topic I'm going to discuss. Every surgical procedure has a high risk of morbidity and substantial risk of mortality. The entire operative team, the operating surgeon, the general surgeon, the intensivist, the anesthetist, the cardiologist, everybody should have a clear understanding of what is to be done for this patient, especially they are going for a visceral or major laparotomy kind of surgeries. Increase in right to left shunt is important in this group. So increased cyanosis, they are very sensitive to fluctuations in systemic vascular resistance. There is a risk of bleeding, there is a risk of thrombosis. So the risk reduction strategies include: try to use local anesthesia whenever is possible. Try to avoid regional anesthesia. That is what we have also learned from our experience. We are not giving spinal because the fluctuations in vascular resistance is something which is very detrimental to these patients. We are not able to control the patients actually. So GA is preferable if you are really looking for extensive procedures. So pre-op phlebotomy, as I told you, we will consider. Eisenmenger actually are are a group as risk of even post-op death. So they require prolonged post-op monitoring compared to a regular patient. So with that, I might conclude my talk. Thank you for patient listening, and I'm happy to take questions. And thank you all.
Thank you, doctor.